Now, when we think of the mechanism of tricuspid regurgitation, same with the other AV valve, it can be a primary problem. This is a primary problem with the leaflets and or chordal structures. So on the left, we see a congenital abnormality. This is Epstein's anomaly, or you can have a dysplastic valve or a cleft valve or a hypoplastic valve. On the right here, we begin to see some acquired problems of the leaflet. Here we see restricted leaflet motion. This patient was taking a serotonin active drug. Very similar appearance to this valve lesion. This is carcinoid valvulopathy. This is right ventricle, right atrium, sort of the restricted immobile leaflet there. We can have rheumatic involvement of the tricuspid valve. We can clearly see the mitral involvement, but rheumatic involvement here of the tricuspid valve. We can have a flail or prolapse tricuspid valve leaflet, or here we see endocarditis. And so when we look at primary tricuspid regurgitation, this is an important point. Primary TR represents less than 10% of patients that are presenting with tricuspid regurgitation. And when they do, 2/3 of the time it's related to this cardiac implantable device. And this is what we see here on this 3D transthoracic image. This is the device lead, and we'll go over this in more detail, this type of imaging, in just a few moments. But when you have, say, a pacing lead, of course, it can cause a remodeling of the right ventricle in and of itself and cause a TR. The pacing lead can interfere with the subvalvular apparatus. It can, as we see here, be adherent or adjacent to the posterior leaflet and impede motion of that posterior leaflet. This is an example where the lead actually went right through one of the leaflets itself, causing trauma to the leaflet and subsequently causing tricuspid regurgitation. So the majority of primary TR is actually related to things that we do by putting in these devices. So if it's not primary TR, then it can be secondary TR. This is secondary to non-valvular pathologies. And this represents more than 90% of the cases of TR. It's either a problem of the right ventricle with adverse remodeling or secondary to atrial enlargement, where the atrial get very big, pulls the annulus, and therefore you can have tricuspid regurgitation. So again, most cases of TR that we see in practice are going to be secondary tricuspid regurgitation, and this is mostly related to what Rekha had just shown in the last case she gave to us, which is a patient either with mitral, as in Rekha's case, or aortic valvulopathy, and then another large component here is idiopathic. But I want to recall that most of these patients that we see, greater than 90%, are going to have secondary tricuspid regurgitation. And it's a bad thing to have TR. You can see on the right that mortality increases, and it's graded based on mild, moderate, severe, massive, or torrential tricuspid regurgitation. And you'd say, well, Steve, I get that, because if it's mostly secondary TR, then it's secondary to things like they have mitral regurgitation, or they have poor LV function, or pulmonary hypertension, or RV dysfunction, or atrial fibrillation. But it turns out that even after you correct for some of the comorbidities associated with TR, it is still associated that poor prognosis in terms of mortality increase just purely by the presence of tricuspid regurgitation itself. And there's a lot of people, man, that have tricuspid regurgitation. Here we see between Europe and the United States the incidence and prevalence, and it's actually pretty close to what Sunil Mankat mentioned this morning, to aortic stenosis. So a lot of patients we're seeing with moderate or more tricuspid regurgitation, yet very few of these patients are intervened upon. So very few individuals are having intervention for their tricuspid valve regurgitation. And I don't want to say that it's really a forgotten lesion, but really for us to think about, can we change our mindset? And if we did, could we change the results for these patients? Because this is what the literature shows. And actually last Thursday, we're sitting in the echo lab and doc comes in and he says, TR, well, we're going to operate, but the operative mortality for patients is reported at 10%. And the morbidity or in-hospital major complications about 30%. And that's very much predicted by clinical, biologic, echocardiographic parameters. I mean, these patients are NYHA class 3 or 4, or they have elevated prothrombin times because of passive congestion of the liver, or echocardiographically, there's moderate to severe RV dysfunction. Man, we'd never wait for the LV to be terrible, or for the patient to have class 3 or 4 on the mitral valve, right? But on the tricuspid valve, when we talk about these outcomes and are we too late, it's really perhaps because we're waiting a long time before we're intervening on these patients. And so should we change our mindset for these patients? And would that therefore give us new results? And it's really this Goldilocks principle. We don't want to be too early, but we don't want to be too late. And so when we're trying to make decisions about should we intervene in patients with valvular heart disease, we often turn to the guidelines. And these are the guidelines written in 2014. Beautiful document, lead author sitting in the back, so I'm nervous to talk about it, but needless to say, 235 pages. All of 2 were associated with tricuspid regurgitation. And so we look at the updated, guidelines from the 2020 ACCHA guidelines, 172 pages, beautiful document. Again, about 2.5 pages or so of this whole document is associated to discuss tricuspid regurgitation. And this is an important thing. We'll just spend 2 minutes to just go through this, but this is surgery for patients with TR. This is severe TR, grade C or D, so either asymptomatic or symptomatic. And it's quite clear that if you have symptomatic stage D tricuspid regurgitation, primary, we send them to surgery. Secondary, if they're poorly responsive to guideline-directed medical therapy and the annulus isn't too dilated, the PA pressure is not too high, we would send these patients to surgery. But what about asymptomatic patients with TR, right? Because for mitral, the other AV valve, we're often intervening before the development of symptoms. If you look at the guidelines, they only talk about primary tricuspid regurgitation. That's less than 10% of the patients that we see with TR, and there's really no sort of guidance for us on how we should intervene or when we should intervene in patients with secondary TR. And remember, secondary TR is over 90% of the patients that we see. What we do know and what we've been seeing this morning is that we're seeing a change in the face of the cardiac operating room, clearly, right? From less and less open surgical procedures to more and more transcatheter-based approaches. And the 2021 European guidelines give us some insights into symptomatic, severe secondary TR. So these aren't asymptomatic patients, but may be considered inoperable in a heart valve center. We might consider some form of tricuspid valve transcatheter intervention. So beginning to see some insights in what to do for our secondary TR patients, the majority of patients with which we see. What are the device options? It would make sense that you can have annuloplasty rings, you can have transcatheter edge-to-edge repair, as Rekha was just saying, with the TriClip or the Pascal device, which is basically a clip with a little spacer device in it. You can have heterotopic valve replacements. You're not really dealing with the TR, but you're putting a valve in the SVC and the IVC to sort of address the back pressure issue. And very exciting is orthotopic replacement with valves itself, like the Intrepid valve or the Evoke valve and so forth. So if we're going to change our mindset and think of new results, I really think we need to address all 5 of these. We need to assess symptoms. How do we evaluate RV size and function? How do we assess the anatomy of tricuspid regurgitation, quantify the degree of TR, and assess PA pressure? And in fact, each one of those 5 things we could spend an entire sort of 20 or 30 minutes on. But what I wanted to do in the last few minutes that we have is really to look about how we assess the anatomy of TR. All the images I'm going to show you are going to be transthoracic images, and I hope to inspire you to think about how you can use some of the new software if you have it, or to play with your equipment to sort of get some of these images and see what you think. So let's think for a moment about the tricuspid valve anatomy. There is an annulus. It's more of a virtual structure than on the left side because it's not so much fibrous component. The only fibrous component of the tricuspid annulus is really here adjacent to the aortic valve. Then there are generally 3 leaflets attached to the annulus, the anterior, septal, posterior leaflet of unequal size. There are then the cords, the papillary muscle, and the adjacent right ventricular wall. And that the proper function of the valve depends on its structural integrity and the dynamic functional coordination of all of those components. So let's take a moment to think about the tricuspid annulus. This is a 3D transthoracic image. We're looking up from the ventricle through here, the mitral valve on this side, tricuspid valve on this side. This would be the anterior portion. This would be the posterior leaflet. This would be the septum adjacent to the septum itself. Now, it's interesting that when the annulus actually dilates, it tends to dilate from the point of the commissure between the anterior and septal leaflet more towards the posterior annulus. And so have you ever wondered, right, when you look at the surgical literature and the surgeon goes in there and they actually take a ruler and they measure how dilated the annulus is, they use a number of like 70 millimeters or 71 millimeters. And in echo, we use a measurement of 40 millimeters or 21 millimeters per meter squared. Because what the surgeon is measuring is really the direction in which the annulus is dilating. We as echocardiographers, we're measuring more of this sort of medial lateral annulus. It's not even the direction in which the annulus dilates. And really, we have no good ways from 2D echocardiography to measure the tricuspid annulus. It's a bold statement, but really, and I like to talk about this, but there's really no good, reliable, reproducible way to do that. But that's why there's the difference between the surgical and the echo literature. What about the papillary muscles? Well, there's great variability in the number of papillary muscles, anywhere from 2 to 9. There's usually 3 papillary muscles, anterior, posterior, and septal, that correspond nominally to the leaflets of the tricuspid valve. And in difference to the left side, the papillary muscles for the tricuspid valve, and this is important, generally apply or supply chords to the associated leaflet. Septum to the septal, anterior to the anterior leaflet, posterior to the posterior leaflet. Now, the tricuspid valve also, you'll see in the septal leaflet, there will be chords that go directly to the muscle itself, to the myocardium itself. But in the mitral valve, there's cross-chordal attachment. So the anterolateral papillary muscle will supply chords to both the anterior and posterior leaflet and vice versa. And why is that perhaps important? Here's just an example. This is the right ventricle, right atrium. If we had in pink cross-chordal attachments from the papillary muscles, as the ventricle actually dilated, you could see it would almost cinch the leaflets closer together. But on the right side, in the absence of cross-chordal attachment, as the ventricle begins to dilate, you're literally ripping the leaflets apart. So we see much more prone to develop tricuspid regurgitation, secondary tricuspid regurgitation due to dilation of the right ventricle. Now, what about looking at the leaflets itself? And we generally look at with 2D echocardiography, right? But there's 3 leaflets, so in 2D we generally are only able to see 2 of the 3 leaflets. So what leaflets are we looking at in a particular view? And this gets confusing because if you look at some prominent echo textbooks or at the literature, there's great variability in what they describe. So, for example, Roberto Lang and his team in this 4-chamber view, right ventricle, right atrium, says the leaflet that's attached to the septum is the septal leaflet. Same thing that Badano and Zamorano had said. But on the other side, Roberto says posterior leaflet 91% of the time, and Badano and Zamorano, they say anterior leaflet 100% of the time. So there's great variability even amongst our mentors and our colleagues as to what are we actually looking at. So let's take a look. This is right ventricle, right atrium, and I'll just say it out loud because I have some of my Mayo colleagues here. These are the Mayo standard views. These are going to go away because with artificial intelligence that we've heard this morning and the algorithms, I hate to say it, after 25 years of imaging in the Mayo way, I can see that changing. Sorry, guys, but I think that's going to happen for us. But this is right ventricle, right atrium. What leaflets are we looking at? Septal leaflet, of course, attached to the septum. This is what Dr. Roberto Lang and his team was telling us. So Roberto says 91% of the time posterior leaflet. So here's the point. We're not sure where we're cutting. It could be the septal and posterior leaflet, or we could be cutting the septal and the anterior leaflet. It's really not clear from this 2-dimensional image. One clue is if we see the coronary sinus, we're probably more posterior, and this then would be the posterior leaflet. But of course, we have 3-dimensional echocardiography. This is a transthoracic image. This is, again, same picture. I show anterior, posterior, and then the leaflet adjacent to the septum would be the septal leaflet itself. And you can see if we're cutting across this way, we would have the anterior and the septal leaflet. If we were cutting across this way, we would see the posterior and septal leaflet. And on the 2D image, they look very much exactly the same. But this is a 3D transthoracic image. We're looking from the right ventricle. And by convention, we put the septum at 6 o'clock. So we just rotate the z-axis so that it would be at 6 o'clock. Then if I'm looking up, I know the posterior leaflet's on the left and the anterior leaflet is on the right. And as we play this through, we can see septal, posterior, and anterior leaflet. Again, from the perspective of the RV looking up, septal, posterior, anterior leaflet. If we're now looking from the atria down, then we flip the posterior and anterior from the right and the left side, which would make sense. These are transthoracic images. Now, this is an image courtesy of Roberto. This is just 2 4-chamber views. And I think it's very hard for us to say that we could see that there's much difference between these 2 RVs and tricuspid valves. But what he shows us here is that the one on the top, we're looking at septal and posterior leaflet. The one on the bottom, we're looking at the septal and anterior leaflet. So transthoracic 3D really eliminates some of the ambiguity in trying to decide which leaflets we're looking at. In the RV inflow view, the leaflet on the top is usually the anterior leaflet, and the one on the bottom, if it's attached to the septum, could be the septal leaflet, as we see here. Why? Because we could be going through here the anterior and the septal leaflet, but if we're not totally seeing the septum, we're not sure if this is the septal or the posterior leaflet. And so we could be cutting, just missing the septum. It still could be septal leaflet, but if we cut a little further away here, it could be the posterior leaflet. And on 2D echo, there's no reference anatomic landmarks that really help us to determine what leaflet we're actually looking at. Again, this is courtesy of Roberto because it's such beautiful images. These are 2 inflow views. Again, 2D, they look exactly the same. It's just that the one on the top is the septal and the anterior leaflet, so anterior septal, and on the bottom it's septal and posterior leaflet. No way we could figure this out without transthoracic 3D imaging. Now, this is a view I really like from 2D. So just think about this for a moment. So we've thought that in the 4-chamber view, the leaflet attached to the septum, we feel confident is the septal leaflet. And in the RV inflow view, the top leaflet is the anterior leaflet. We feel confident about that. In this view, the leaflet furthest away from the aortic valve is probably the posterior leaflet. Why? Because if we look at this image here, you can see adjacent to the aortic valve, you're not sure if you're going to hit the septal or the anterior leaflet, but the leaflet furthest away is probably the posterior leaflet. So the 4-chamber view, we feel good about what's the septal leaflet. The RV inflow view, we feel good about what's the anterior leaflet. And in this view, from the peristernal short axis view, the leaflet furthest away is probably the posterior leaflet. Notwithstanding the fact that we really love transthoracic 3D imaging, this is an image that I'd shown earlier before, just looking from the right ventricular perspective, eliminating some of the ambiguity of what leaflets we're looking at. So you start taking these pictures and you ask yourself, well, how many leaflets does the tricuspid valve have? You say, well, it's tricuspid valve, it must have 3 leaflets. And nominally that's true. There's 1, there's 2, and there's 3. So then I look at this valve. Again, I'm looking up from the ventricle, and I say, well, how many leaflets does this one have? I see 1, I see 2, I see 3, I see 4. This is a quadricuspid tricuspid valve. Huh. Then I look at this one, and I say, well, this has got 1, 2, 3, 4, 5. Maybe this is a pentacuspid tricuspid valve. And so you've come to realize when you start doing this that it's not always, a tricuspid valve. And you can really appreciate why this valve leaks, because there's this big, as Rake had just shown us on the mitral, you can see here that there's just no coaptation in the central portion of these leaflets. It's very helpful to help understand some of the anatomy of TR. What about this one? This has got 1 leaflet. This is a bicuspid tricuspid valve. And so Becky Hahn had looked at this, and others from pathology slightly varies, but they type the valve leaflets. Type 1 is the 3-cusp valve. That's easy to remember. Type 2 is a bicuspid valve, 2 for 2 cusps. And then type 3 is the 4-cusp valve, and type 4 is 5-cusp valve. And it turns out that about half of the time, it's a tricuspid valve, and about 45% of the time, it's a quadricuspid valve. Other literature, actually, from South America, looking anatomically at it from a pathologist perspective, they said 54% of the time these were quadricuspid valves. You go, well, it didn't really matter all that much in the surgical era, but in the transcatheter era, and particularly if we're thinking about edge-to-edge repair, it's very important to begin to understand some of the nuanced differential components of its anatomy so we know potentially where to place these clips. And I'm not going to go into detail about this, but for reference, this helps us to understand some of the anatomy of TR. So 3D gives us a pretty good perspective of the tricuspid valve. Now, I just wanted to take 2 seconds to talk about pacing wires, because that's in the primary areas, about 2/3 of patients, it's related to problem with the pacing wires, perhaps. So here we see the wire. This is the septum. We've oriented that at 6 o'clock, so I know the leaflet on the left posterior, the one on the right's the anterior, and here we see the pacing wire. We can see the leaflets moving pretty freely here. Ideally, we'd love to see this, pacing wire, should have gone back, in the commissure between the septal and the posterior leaflet. And in that case, this is the right ventricle, right atrium here. We don't see much tricuspid regurgitation. So here we're just going to look at a pacing wire that was adjacent to the leaflet. Push too fast. But here, let's take a look here. We see this pacing wire. It is adjacent to the posterior leaflet. This is septum, posterior, anterior, because we're looking up from the right ventricle. This patient has a whole lot of tricuspid regurgitation. So the question is this device lead associated? Here are some of the 2D images. We felt this is probably the anterior leaflet. We weren't really sure if this is septal or posterior leaflet, all the things we had gone through. Still trying to figure out whether this is pacemaker wire impingement. So we went to 3D, and here we see this device lead adjacent to the posterior leaflet. If I look from the right atrial perspective, I see the device lead really adherent and adjacent to this posterior leaflet. And if I stop and I just sort of play back and forth slowly, you can see that that posterior leaflet motion is being impeded by the adjacency of that lead. And although not the easiest thing to do, what we asked to see if they could is to reposition the device lead, which they did. And we can see pre, and here this is post. This was a few years ago. We were just getting into this, one of the early cases that we did, but we had a great result. And again, it's not always easy to reposition the leads, but in this case, they were able to do that, and we were able to eliminate the tricuspid regurgitation. So I leave you really with the thought that maybe with tricuspid regurgitation, it's time to change our mindset. We need to assess these 5 things, and I hope to inspire you with some transthoracic 3D images about how we can really look at the anatomy of tricuspid regurgitation. Because TR has significant clinical and prognostic implications, and it really should be taken seriously. We are seeing a change in the face of the operating room, which is aligned to develop strategies to address these leaky tricuspid valves. And comprehensive 2 and 3D echocardiography provides unique insights into the anatomy and severity of tricuspid regurgitation, and I think is really critical in helping us to define the most appropriate treatment options. I really thank you so much for your time and attention.